Thank you so much, everyone, for joining JOMA tonight for part one of our webinar series on cystic fibrosis, Sweat to Solutions, your cystic fibrosis crash course with Dr. Gita Lisker and Dr. Brocha Tarshish. Tonight's webinar is co-sponsored by Vertex. Thank you. The Jewish Orthodox Women's Medical Association is a dynamic organization of over 600 Jewish Orthodox women in medicine, dedicated to professional growth, community service, and advancing healthcare knowledge. Through education, mentorship, and advocacy, JOMA empowers its members and promotes health and well-being within our communities. Thank you for joining us as we continue to support and inspire women in medicine. For more health topics, check out our upcoming webinars and tune in weekly to the JOMA podcast. Before we begin, if you did not complete your pre-webinar survey, we'll be posting it in the chat. There will also be a post-webinar survey following the webinar that we will also post in the chat. So in order to be counted for our giveaway or gift card giveaway, please be sure to fill that out, and we will post that in the chat very, very soon. Our first speaker tonight is Dr. Gita Lisker. Dr. Lisker is the director of the Respiratory Care Unit of Long Island Jewish Medical Center. She also holds the position of the director of the Hospital Outpatient Management Experience Home Program and director of the COVID-related outpatient work Navigators Crown Program, both at Northwell Health. In addition to her directorial roles, Dr. Lisker is an associate professor of medicine at the Donald Zucker School of Medicine at Hofstra Northwell, within the division of Pulmonary, Critical Care, and Sleep Medicine. Dr. Brocha Tarshish is a board-certified medical geneticist with a background in obstetrics and gynecology. She originally trained as an OB/GYN and worked for a short time in that field before pursuing further training in clinical genetics at Emory University. She previously worked as an assistant professor of medical genetics at the University of Miami and as director of newborn screening for South Florida. She currently works as a medical director and subject matter expert for Cigna, where she also serves on the Medical Affairs Committee. She lives in Atlanta with her husband and 3 children. She's passionate about genetics education and about helping to demystify the topics of genetics and hereditary disorders for individuals in the Jewish community. We thank both of them for being here and we look forward to hearing their thoughts on cystic fibrosis.
We're gonna speak together a little bit about just understanding cystic fibrosis, and we'll start with an introduction to cystic fibrosis. So the definition of cystic fibrosis, what it is a genetic disorder that affects the respiratory, digestive, and reproductive systems. And just really the hardest part to manage is the way it affects the respiratory system. It's at this point, or until very recently, still a life-limiting and life-shortening condition. There are some really recent advances that really have been game changers, and we'll talk about those later. It's got an autosomal recessive inheritance pattern, which means that both parents need to carry an abnormal copy of the gene involved in order to give their child this disorder. Its hallmark is the production of thick, sticky mucus in various organs that affect the function of those organs, especially the lungs, especially the respiratory system. It affects about 70,000 people worldwide, but it affects populations at different rates. It's most common in Caucasians, about 1 in 2,500 to 1 in 3,000 live births. And it's about equally common in the Ashkenazi Jewish population. It's less common, but still found in certain ethnic groups that are non-Caucasian, including about 1 in 17,000 African Americans and 1 in 31,000 Asian Americans. In general, it's common in populations of European descent. And it is a lethal disease. It is considered the most common single gene lethal disease in this country. It's caused by mutations in the CFTR gene. There's over 2,000 known mutations, but not all cause disease. But there are some that or not all cause the severe disease. And there are some that you find over and over again and that are very common. The most common mutation is called the Delta F508 mutation. It's present in about 90% or more of CF patients. In at least one of the abnormal copies has that genetic change. The gene is located on chromosome 7. And what it does, and the reason why having two abnormal copies of the gene causes disease, is because this gene provides instructions for making the CFTR protein, which is needed for salt and fluid regulation. If you don't have good flow of that, that leads to disease. And it basically it codes for a chloride channel in the cells lining, in epithelial cells, the cells lining the respiratory tract, so cells in the GI tract, etc. So why does a mutation in the gene cause cystic fibrosis? So the CFTR protein acts as a channel in cell membranes that transports chloride ions. It's a 3D channel that needs to be kind of held open to allow chloride ions to pass through, which also affects water movement and sodium movement. And so it's really affecting the transport of sodium and chloride ions, and that allows for proper consistency of mucus in the airways and in other organs. If there isn't proper transport, water follows ions, and if there isn't proper transport, then the mucus gets drier and thicker than it should be and harder to clear, and it leads to other issues. So defective CFTR protein leads to thick, sticky mucus. There's reduced chloride secretion, increased sodium absorption. So the airway surface liquid, it gets dehydrated. It should be thin and watery, and it gets thicker and drier. Mucus clogs not only the airways, but also the ducts of the pancreas, like the tubes that are sort of leading from in and out of the pancreas. So in lungs, this affects the way that mucus is cleared. If mucus just sits there, it leads to bacteria growing and leads to infections. In the pancreas, it blocks the ducts that carry enzymes that are needed for breaking down fats and other parts of food. So this can cause problems with digestion. In general, that's something that they've been able to sort of fix and help with more than all the lung problems, but it is an issue. So it leads to chronic respiratory infections because, again, the mucus is it's drier and thicker than it should be, and it's sitting there. There's coughing, there's the mucus is sitting there and sort of growing bacteria. The pancreatic insufficiency, the fact that the pancreas is not working as well as it should, affects most cystic fibrosis patients. That can lead to malnutrition and poor growth, although that can be helped with certain enzymes that we'll talk about. It leads to infertility in males because the vas deferens, which is needed for the carrying of sperm, for the movement of sperm, is blocked as well. And that's very, very common in male cystic fibrosis patients. And so there's ways to intervene using artificial reproductive technology, but most males who have cystic fibrosis, not carriers, but those who have the disease, actually can't have children without intervention. Okay, so I think next slide.
Okay, thank you. So I'm trying to get rid of this bar on top, but I'm not having any luck, so I apologize. Okay, so we're going to go on to the symptoms of cystic fibrosis, and just to note, before it became normal to screen pretty much all newborn screening, which is now pretty much standard in this country, infants used to present pretty classically either immediately after birth or a short term later, generally with trouble with their breathing, and also things like meconium ileus. In other words, their bowels were getting stuck because things were not moving through fast enough. Pretty much with the onset of the universal screening of the newborns, symptoms are still there, but at least we know when to look for and to kind of look out for it earlier. So the classic symptoms that we're going to talk about are those of the classic mutation, the delta F508. More interestingly, just even since I started my training and my practice, more and more as we identify more mutations that are more unusual, some of the symptoms are atypical and may not be severe. But what we're going to talk about now are pretty much the classic symptoms in in the classic mutation. So I'm a pulmonologist. I mean, the pulmonary symptoms, respiratory tract. So the respiratory tract, pretty much we're going to include anywhere from starts at the nose, goes through the sinuses, and then down the airways and into the lungs are most commonly what's affected and ultimately cause the biggest problems. So because the mucus, it sounds like not a very big deal. I mean, how much disease is being caused just because your mucus is off? But having that very thick mucus really affects things in a very significant way. So normally, when you breathe in, your respiratory system from your nose down to your lungs is protected by a thin layer of mucus that acts as a protective barrier when things come in, and allows the lungs, the sinuses, the nose, everything to protect themselves from infection. So when that mucus is very thick, number one, it gets stuck in the airways. You have trouble coughing it out. And because of that, you have trouble getting rid of it, it tends to get infected. And so that's what usually starts this pattern, even from a very young age. You may start with chronic, cough that you have all of the time. You might start to have asthma symptoms, trouble breathing, wheezing, shortness of breath when you're trying to do something. But then as the infections come in, and at the beginning, early in life, they may be your more standard bacterial infections. But as you get more and more infections, the airways get more and more damaged, which leads to lung damage. And then it just becomes a very bad cycle of the more damaged they are, the more infections you get, et cetera, et cetera. So, and that will lead to chronic issues with your breathing that will start from the sinuses, from nasal polyps, sinusitis, snoring, change in voice, shortness of breath, and ultimately with these lung infections and basically destroyed lungs as time goes on, as the airways become dilated and dilated. Well, again, with the screening, we kind of know from the beginning, but the way that we can confirm the diagnosis of cystic fibrosis, somebody who has the classic symptoms, as Dr. Tarshish mentioned, because it's a defect in the chloride channel, patients' sweat actually is saltier than somebody's normal sweat, and so it's a pretty simple test to do, which is measuring the chloride levels in a sweat test, which will confirm the diagnosis. But really, pretty much at that point, and in today's day and age, especially because of the wonderful new therapies that we have, what you'll want to get is genetic testing to really specify, not only confirm the disease, but see which mutation that you have to guide therapy. So this goes really straight to treatments about what we're trying to do. This is the standard of care until about 8 to 10 years ago, which was we didn't have anything that was going to change the genetics or the actual thing that was causing the problem, but we were the actual cause of the disease, but we were just trying to do our best with therapies to help, basically to help the mucus and help with infections. So the idea behind this was, number one, let's try to thin the mucus in the lungs. So we thin mucus in the lungs. There's inhaled medications whose job it is to break down DNA proteins. And so by inhaling that, it breaks down the mucus to try to make it thinner. That's called the Dornase alpha. We use saline, just salt water, but a very concentrated salt water via nebulizer to help, again, loosen up those secretions, but more importantly, to help mobilize them and help you cough them out. We'll use standard medications that people may know from asthma, like albuterol, to try to relax the muscles in the airways, to prevent them from spasming and wheezing, and again, to try to help loosen the mucus. After that comes mechanical. So that's really trying to loosen the mucus by breaking down proteins, by allowing the airways to relax. And then we have devices that try to now help bring those secretions and that mucus up. So there's manual percussion, which is literally banging on someone's back. Patients generally will have a vest which is what it sounds like. It basically goes something that you wear that vibrates, shakes up the chest wall, just to try to loosen up that mucus, get it off from wherever it's stuck so you can cough it up. Other devices that you blow into, again, with the same idea, to try to, once that mucus has been a little bit thin, to break it off wherever it's hiding so that you can, so that patients can cough them up. These tend to be very time consuming. So at least to do this twice a day, every day, sometimes more. And, you know, this may take a regimen that may take a half hour, 45 minutes. You know, these are kids, young people, teenagers. So the compliance with it isn't always great. And again, this is always not addressing the actual problem, but almost of a Band-Aid. More than that, after a certain point, as the infections keep coming and keep coming, people start getting infected with worse and worse bacteria. So it may just start with your standard bacteria that everybody gets as a kid, and then it moves on. And these severe bacteria, and combined with the damage already to the lung, once they're there, they're almost impossible to get rid of them. And so people might be on an inhaled antibiotic to just try to keep it suppressed, because once it's there, you can never really get rid of it. And eventually people also become infected with these bacteria that are actually resistant to sometimes almost every antibiotic that that is around, and that actually becomes one of the biggest problems that lead to major issues. So I'm gonna just go from there, hold on. The other things that we can talk about, which other places, like that was mentioned in the last and previously, is that other places that where you have glands that secrete things, which are called exocrine glands, meaning they're secreting something into another organ, like the pancreas. So the pancreas, you might know, if you take biology, has two different functions. Most people know about, well, many people know that the pancreas is related to insulin and diabetes, but it also produces enzymes that get released into the digestive tract to break down particularly fats and other things. So when the pancreas has trouble getting those enzymes into your digestive tract, food doesn't get absorbed. When people go to the bathroom, the stools tend to be fatty, greasy, and you have malabsorption and malnutrition. Cystic fibrosis patient population is pretty much one of the few times that you're going to hear people saying, "Yay, I gained 2 pounds." You know, patients tend to be malnourished and undernourished, and keeping them nourished is one of our highest priorities. Oh, let me go back. Sorry. So there is pancreatic replacement therapy, which again is pretty standard for patients with cystic fibrosis. They're taking these basically enzymes that the pancreas is not getting to the digestive tract like it should. They're taking it with meals so that it can help them break down their food. They're going to try to eat as high nutrition, as high caloric content as they can. Again, there's malnutrition. There's the fact that it takes once you reach a certain point, it takes so much energy for your body just that you're to work on your breathing, that it's using up calories constantly. They need a vitamin replacement, again, because of malnutrition. And these are really the common things. Well, before we even get to the what's next, I mean, the natural history, let's just, talk about where we were. So whereas, I don't know, in the 1980s, patients, especially with the classic cystic fibrosis with 2 bad copies of the genes, maybe would live into their 20s. Pretty much respiratory failure ultimately, and recurrent infections that are now resistant to antibiotics was going to be what was going to lead to outcomes and death. As some of the therapies improved, life expectancy, moved upwards, maybe into the 40s. Again, for the standard cystic fibrosis genes, there are patients that we have in their 70s and 80s, but those are generally different genes, not the classic ones. And then ultimately, the patient was going to rely pretty much on a lung transplant. And once their lungs completely failed, a lung transplant would have been necessary. to save their lives. Has to be both lungs, as opposed to other lung diseases where you can just do one lung because you only need one lung to live. The problem is that these lungs are so infected that you had to completely take out both and find a good fit. And patients were already so sick and malnourished, and so it's not a great solution. What came about, I think Dr. Tarshish was going to take over talking about just how they work, but in the last 10 years, what has come about is genetic therapy for cystic fibrosis that has made such a huge difference, to the fact that the average life expectancy, jumped basically 20 years. Quality of life has gone up tremendously. Lung function and tolerance has gone up tremendously. Births have gone up tremendously, both male and female. Even women with cystic fibrosis, they don't have the same universal infertility, but because of actually changes in the cervical mucus, it makes it more difficult. And so these new therapies have they're just game changers. They're really truly life changing and very exciting. So I'm going to turn it back over to Dr. Tarshish to talk about the therapies.
Thanks. So what's next, or what have been used in the last 10 years? So they're not gene therapies per se. If you think of gene therapies as therapies that really deliver functional copies of the gene, like working copies of the gene to the area of the body where it's going to be effective, that's not quite what is going on with these new therapies. And we're not there yet, although that's definitely an area of research and something that people would love to be able to bring to the market. Right now, we have something probably as close as we've gotten, and definitely life expectancy lengthening and quality of life improving medications. And those are really what they're targeting. Is they're not fixing the gene, but they're able to help the protein, that that ion channel, work better. So we have CFTR gene modulators. What they're doing is they're working on the problem with the CFTR protein, with that ion channel. So we have CFTR modulators, which sort of, think of it as it's holding the gate open to allow better ions flowing through. And so those alone, the first one we have was ivacaftor. That's going back over 10 years. It was approved for mutations or gene changes where the problem actually was where the gate would not be open enough for, long enough, or the gate was not working properly. So that was, a less common mutation called G551D. And some other changes like that. After that, they were able to, so those are modulators. Then they were able to get to, so the potentiators are help with those. Modulators are sort of this new class that include something called potentiators and something called correctors. So potentiators like ivacaftor do that, and they're sort of like holding the gate open and helping with conduction of the ions, because there's electrical activity there too. And then correctors were actually helping the CFTR protein within the cell, like form the right 3D shape, and then move out to the outside of the cell where they can do their work. So ivacaftor was the first one. Again, it was helping kind of keep the gate open. Correctors, the first corrector was lumacaftor. It was helping the protein form the right 3D configuration and move out to the outside of the cell. And now we have combination therapies, and that not only does that work better because it's working on two problems with the CFTR protein, with that ion channel, it also sort of universalizes the being able to correct the problem, because we can help people with more mutations. So some combination therapies, so this relatively rare mutation was helped with ivacaftor. Then they brought out combination therapies, and if they have two copies of delta F508, which is the most common mutation, but not everyone has 2 copies of it. That helped it as well. Like you could help the CFTR reach the cell surface. But now we started combining them more, and we have triple combination therapy called trifacta, which is for anyone with even one delta F508 mutation. And it's very effective for them, which is over 90% at least of American cystic fibrosis patients. And that really has been, like Dr. Lisker said, the game-changing type of therapies, because they're really, there's the other care, lung, chest PT, and antibiotics and other things that sort of thin the mucus. Those are helpful. Those are what's up until now up until 10 years ago have been able to sort of like slowly and incrementally increase life expectancy and increase lung function and help with just help with quality of life. But these are actually targeting, not changing the gene, but they're targeting the problem. And they're actually helping because the ions are moving through more effectively. They're thinning out the mucus. They're helping sort of normalize like lung function and mucus production. So that's used now. It actually, trifacta up until a year ago was only for kids 6 and over. First it was for older kids and adults. Then it was approved for kids 6 and over. It was just approved a year ago for kids ages 2 and over. So that's before a lot of the damage to the lungs has taken place. And so that is really what's like for now, really like almost normalizing life expectancy, normalizing quality of life in keeping these kids, like keeping infections away, and keeping kids just being able to, and adults with CF just able to sort of live their lives without like going to the hospital. It helps with cough. It helps with just having the mucus flow. And gene therapies are a dream. They've been working on it for over 30 years. There's a lot of problems with it. I think someday this will be the next step. There's problems with, just kind of, it has to be given in something. It's given in, it's given in a type of virus called adenoviruses. Those have caused some problems. Then they make the viruses not infective, but it's still, it still can cause complications, or it has to be given all the time because there's turnover of the lung epithelium, of the lining of the lungs. They'll also, people, the CRISPR and Cas9, there was back in December, they were able to approve a medication that edits genes to correct the defect that is what causes the problem, to correct the defect that causes the problem in sickle cell anemia. But cystic, so now there's a question, why can't they just use CRISPR and Cas9 and just edit the gene, edit out the faulty DNA and have a perfectly functioning gene, and that would be permanent. And they are working on it. But again, there's challenges to that make it harder to just create that than it would be for sickle cell anemia. But these are emerging therapies. They're going to, probably soon, within the next few years, they're going to actually be able to deliver functional copies of the gene in maybe something that could be a more permanent cure, because trifacta is given continuously. It's an oral medication, which is really incredible because that's so convenient. It doesn't need to be, an infusion, but it still is something that it's expensive. Some people don't tolerate it. Some people don't respond. Some people sort of lose that response. So if we could really edit out the faulty DNA, then that should be able to help everybody. And then again, there's that class of cystic fibrosis patients who won't respond because of their mutation. And if we could actually edit out any mutation, then that shouldn't be an issue. But those are more for the future, probably within the next few years, but not currently available. Although there are trials going on for all of these. So stay tuned.
This is, I think, in a way, we kind of went over this. I mean, there's tons and tons of complications related in cystic fibrosis. I think we're going to be seeing all of these, honestly, just less and less, especially for those who have, again, over 90% of people that have the mutations that will respond to trifecta, now that we can start it so early on and young in life, that most of these complications that develop, the chronic infections in the lung that start out as simple infections and then turn into these multi-drug resistant bacteria and fungi and which coughing up of blood or collapse of the lung, like the pneumothorax, all of these things, if we can really address now, starting very young as age 2, to prevent the damage from occurring in the first place and to prevent the first and the second and the third and the fourth and the fifth infection, then hopefully down the line we'll really be able to help with that. Same thing with even with the diabetes. The reason that diabetes happens is the pancreas again becomes more and more basically scarred or inflamed, however you want to think about it, and interferes with insulin. That again, these therapies are going to be helping with all of that. And, people, even once they get a lung transplant, one could say, oh, you could even stop such a therapy because the lungs are better, but it would even still be necessary to prevent everything else. There are a whole host of other complications that patients with cystic fibrosis get related to malnutrition, related to recurrent infections, severe blood, low blood counts, malnutrition, bone health. And so all of these are things that are consequences of the original problems. Then if we target the original problems, these will very excitingly, even before the actual gene therapies come out, really is just making a huge difference. Here's the care team. Sorry, obviously, I'm going to move this down here. Oh, finally. Yeah, I guess the point is, I think anyone can appreciate after listening to all of this and realizing how complicated a disease this is and how many organs are involved, and of course the stress and that comes with it for the patient, for the child, the stress that comes with it with the parents, the fact that this runs in families, and so very often you'll have younger children with cystic fibrosis who've already seen what their older siblings have gone through. I mean, the psychological stress of that is tremendous. Psychological stress on the parents who often, may have actually multiple children going through it. And so obviously it's a huge care team. Cystic fibrosis generally, I mean, where I am, we're a cystic fibrosis center. I'm an adult. We have, starts out with a pediatric cystic fibrosis center. They tend to transition, usually not at 18 or 21, sometimes at 25 or 26, because they're so attached, over to the adult. And so this is a huge team that's related around it, from the doctors for the various organs that are involved, to the physical therapists, obviously the mental health providers. Social work is a huge need, geneticists, and then the advocacy, actually, which is at the bottom, if I can move this around, even for the CF community, and now even just fighting with insurance companies to make sure that genetic testing can be done in the first place, and then to make sure that these new expensive therapies, which of course are not really expensive in the long run because the therapy is expensive, but it is nothing in comparison to the treatment and the recurrent hospitalizations and the lung transplant. So there's a huge cystic fibrosis community, and it wraps around the patients and the families to help. And I believe that was that. I'll send it back to Adina.
Thank you so much, Dr. Lisker and Dr. Tarshish. So we did have a question come in, and I think we have some time as well if anyone has any additional questions that they'd like to send in. So I'm just going to ask, and I'll let either one of you respond. So if this is an autosomal recessive disorder, how could patients with cystic fibrosis have only one copy of the F508 del allele? Wouldn't those just be carriers? Don't you need two copies of the mutation to actually have CF?
So these patients have each copy of their CFTR gene is abnormal. It has a change. This delta F508 is the most common mutation, but there are other ones that cause disease. Delta F508 is a classic mutation. Dr. Lisker talked a little bit about like classic versus non-classic, or just the milder forms of the disease. And the patients that she sees, let's say, who live to their 70s or 80s, typically those are patients who have one classic mutation, like Delta F508, or another classic or severe mutation that really just takes away the function of one copy of the gene. And the second mutation, the second change, and again, you do need two to cause cystic fibrosis. The second mutation is one that doesn't affect the gene, or doesn't affect the gene product, which is the protein, which is that ion channel quite as much, so it still has some function left. And there is even carriers alone, if they have a classic mutation, can have more of a tendency to have sinus disease. They can have more of a tendency to develop pancreatitis, which is a bad inflammation of the pancreas, but they won't have cystic fibrosis itself without a second mutation, whether it's like a classic severe mutation or a milder one that doesn't damage the gene and the protein product of the gene as much.
Thank you. We got two more questions.
Did you
want to say something, Dr. Lisker? Okay, great. Okay, so the next question: when it comes to the trifecta medications, do the patients who have issues tolerating the ion changes present with neurological issues, cardiac issues, etc., due to the electrolyte imbalance?
Dr. Lisker, can you?
I don't. Yeah, no, I don't think so. Usually, I'm not sure. Maybe I'm not understanding the question, but generally, it corrects the ion imbalance, right? The imbalance is corrected. Right.
Yeah. Okay. Okay, and the next question, and this might also come up, I think, in our next webinar, which we definitely encourage everyone to attend as well, but maybe you can speak to it a little bit. Has the incidence of cystic fibrosis in the Orthodox community decreased with the inclusion of cystic fibrosis in the Doria-Sharon panel? I don't know if you want to speak to that a little bit.
Yes, and it's not just or the Orthodox community doesn't just utilize Doria-Sharon. They utilize the community utilizes other forms of genetic screening or carrier screens, and the incidence has decreased. I'm not sure about numbers or percentages, but yes, it has. And then the incidence in, I believe, other American populations overall, especially now that carrier screen really, it's just universally or offered for all pregnant women in the United States, especially for cystic fibrosis was the first one. When I was an OB resident nearly 20 years ago, there was this carrier screening was recommended. It was given even in our, within our clinic population in the private practices. And that has, so, I mean, if, there were sometimes like where decisions were made about the pregnancy, but also now that it's encouraged to for people before they're pregnant to get what we'd call preconceptual screening, it has decreased the incidence, I believe.
Thank you. So those are all of our questions. I want to thank both of you for coming on tonight. This was incredibly informative. We will be posting this recording to our YouTube channel, so you can always review the content that we shared. If you haven't signed up for our next part 2 webinar, Cystic Fibrosis Carrier Speak, Genes, Dreams, and Choices on August 15th at 8 p.m. Please sign up, please share with your community and your friends. We would love to see as many people here and get information as possible. We're going to post the survey chat again. So we'll leave this webinar open just for a little bit longer. But again, thank you so much for joining us tonight. We really appreciate everyone being here, our speakers, our sponsor, Vertex. This was a really incredible session. So thank you so much.